It's my pleasure to welcome Andrew Campbell, who is your speaker tonight. Andrew is a master's qualified audiologist, certified in audiological and neurological sciences, making him the top in his field for hearing and brain health. Andrew is a speaker, teacher, manager, innovator, and author of Hearing and Brain Health, which became the #1 new release on Amazon. So very exciting. Andrew is one of the founding members of the largest hearing and healthcare groups within Australia, and now the founder of New Audio Hearing and Brain Health. Andrew's work has been recognised as top in his field for his work here within Australia, New Zealand, Taiwan, Hong Kong, Malaysia, Singapore, and the USA. So please welcome Andrew Campbell.
And thanks for taking time out of your busy schedule to come and join us this evening. Who here travelled more than, say, an hour and a half to get here today? Oh, wow. Fantastic. Oh, from Central Coast. Do you mind if I put you on the spot and ask you what made you get dressed, come all the way down here and to this session today? Was there something specific that you wanted to learn? Okay. Excellent. So hoping to learn a bit more about the links between our hearing health and our brain health. Yeah, fantastic. Excellent. Well, that's really going to be the focus of the presentation this evening. So we know that, well, there's a lot of really important research that's been published, particularly over the past 10 years, highlighting the links between hearing loss and cognitive decline, and also what we can do about it. Yet we know that this is a topic that's not really anywhere near what we might consider to be common knowledge in the community. A recent survey was done on the Australian public just to try to get a gauge of just how well Australians understand that there are links between our hearing health and our brain health. And what they found was that 84% of Australians really had no idea that there was any link between hearing health and brain health. So hopefully you'll learn here, you'll leave here this evening with at least a bit of a grasp of what these connections are. And all of you should have a copy of my book with you in front of you. And this expands upon the topic in a little bit more detail than we'll have time for this evening. And I think it's just important to note too that all the studies that we will talk about, the statistics and so on, they're from really high quality studies done in the top academic journals, and all the references are at the back of the book if you really want to dive in deep with that. But in my 22 years of doing this kind of work as an audiologist, there really has not been a week that's gone by where I've not come across a heartbreaking case of someone that's just simply left treating their hearing loss too late. Also, in my 22 years of doing this kind of work as an audiologist, there's yet to be a week that's gone by where I've not come across a well thought out, sometimes genius level excuse for doing absolutely nothing about a hearing problem. Just when I've every possible excuse under the sun to do absolutely nothing about a hearing problem, a new one comes up and kind of catches me by surprise. But the reality is, we know that most people in Australia with a treatable hearing problem never set foot in an audiologist's office. In fact, only about a third of people that could benefit from having their hearing loss treated ever go and do anything about it. We also know that on average there's a 10-year delay from the point where people could benefit from treatment to the point where they actually go and take action. And what the research is telling us is that that's absolutely 10 years too late. And I can tell you from a, I guess, practical point of view, in having treated hearing loss for a couple of decades, the difference when we catch hearing loss early in treatment versus seeing a patient who's put it off and put it off and put it off for a decade or more, it really is like chalk and cheese. We just tend to get our best results, I guess, when we catch hearing loss in the earlier stages, and we'll highlight some of the studies that are looking what's happening in the brain with untreated hearing loss, and hopefully you'll get a bit of a sense as to what's going on there and why early action is really quite important. The links between hearing loss and cognitive decline have appeared in the medical literature since the 1980s. But the study that really put this topic on the map was published in 2011, done at Johns Hopkins University, and it was really for the first time that hearing was involved in a major multi-million-dollar study of the aging process. So in this particular research, there were 600 people, all aged around the age of 60, and it was a study of the aging process over a 12-year period. So it's what we call a longitudinal study over 12 years. 600 people aged around 60, so they're coming out of that research aged about the age of 72. So these people, to be part of this research, they couldn't have had a history of having dementia. So they were coming into this study dementia-free, and they came into the university every year for 2 to 3 days of really intensive testing. And the researchers were looking at all things known to be associated with aging: coronary heart disease, diabetes risk, cancer, male pattern baldness, arthritis. Hearing was just a very small part of what they were looking at in this research. So after 12 years, huge amounts of data analysis done, and the most stunning and surprising statistics that came out of this major study were the clear links between hearing loss and dementia risk. What they found was that those people that had a mild hearing loss, so a mild hearing loss is about a 25% hearing loss. When I graduated from university over 22 years ago, we didn't really care so much about a mild hearing loss. For those people with a mild hearing loss in the study, they were twice as likely to have developed dementia over that 12-year period relative to their peers that had normal hearing. Those with a moderate hearing loss, so the moderate hearing loss, it's about a 25 to 40% hearing loss. I've got a clinic on Macquarie Street in the city, and most of my patients there had a moderate hearing loss. Those people with a moderate hearing loss, they were 3 times more likely to have developed dementia over that 12-year period compared to the peers that had normal hearing. And remember, these people were coming into this research without a dementia diagnosis. Those with a severe hearing loss, so a severe hearing loss, which is about a 50% or more hearing loss, those people that I mentioned at the beginning that really had put off doing something about their hearing loss, really too late for us audiologists to get a really great outcome. So a severe hearing loss, it's around a 50% or more hearing loss. Those people with a severe hearing loss were 5 times more likely to have developed dementia over that 12-year period compared to their peers that had normal hearing. So these findings, they created quite a stir in the medical community, got a lot of media attention over in the United States. Front cover of the New York Times, not a whole lot of media attention here in Australia. But I'd have to say that slowly but surely, these links between our hearing health and our brain health are starting to become better understood. I had the pleasure of meeting Professor Franklin, who was the head researcher for that study. He was over in Sydney about 5 years ago, initially presenting his research, and he was also over in a public health capacity to try to bring hearing more into the forefront of when we're thinking about diagnosis of mild cognitive decline, dementia, Alzheimer's disease, and just what might be referred to as general cognitive aging. He is of the view that as soon as cognitive decline of one form is suspected, then hearing really should be the first thing that we look at. So his team have essentially distilled, when we're thinking about the links between our hearing health and our brain health, they really talk about three main areas of concern. So first of all, those that relate to social isolation. So a whole set of considerations that relate to the downstream effects of particularly chronic social isolation. We've known for decades that as hearing goes down, that risk of becoming socially isolated tends to increase. And it tends to start with the most common difficulty that we hear in the clinic. The highest level of complaint about this particular topic is difficulty hearing in background noise and group situations. So most of my patients, they're able to hear one-on-one in quiet situations. So without the hearing aids in, most of my patients can hear me one-on-one in quiet. But as soon as they get out into restaurant, cafe, cocktail party, family gathering, that's when the difficulties tend to start. There becomes a point in time where those situations start to become potentially embarrassing. If you've laughed at a joke or missed the punchline of a joke, something like that. Or what people often describe is it starts to feel like they're on a bit like the periphery of conversation, not really directly involved. So in a nutshell, that social interaction starts to become far less enjoyable. There becomes a point in time where quite common for people with hearing loss start to either consciously or subconsciously disengage from those social interactions that they would have otherwise once enjoyed. And that's the point where we really start to become concerned about it. So factors associated with social isolation, that's a whole set of criteria when we're thinking about hearing and brain health. Second set of criteria relates to cognitive overload. So when I'm talking about cognitive abilities, cognitive overload, and so on, our cognitive abilities are things like our short-term memory, processing speed, reaction time, what we call our general executive functions. What we know is that all of these become impaired when we've got a hearing loss that we've done nothing about. And for the most common forms of hearing loss, it's not like people are hearing no words. Most commonly, they're hearing parts of words. Most of my patients are able to hear the A-E-I-O-U vowels without their hearing devices in. However, most commonly, they're missing out on the consonant sounds. And typically, the consonant sounds are the higher pitched parts of speech, and they tend to carry most of the meanings of words. So if you're not hearing all of the consonants, in order to communicate, you need to get that information from somewhere else, most typically from your vision. So body language, facial expressions, movement on lips, they all give us clues as to what that person might be talking about. Often that's not enough, and we need to think of the context of the conversation so we can get the gist, and hopefully we can kind of fill in the gaps based on the topic. The thing is, ask anyone who's got a significant hearing loss what it's like for them after a long day of interacting with groups of different people in challenging environments, and they'll tell you that that process can actually be quite exhausting because it's really quite hard work. Following conversation, particularly in background noise in groups, is one of the most cognitive numbing things that we can do. And if we're not hearing words in full, people describe it kind of like going 100 kilometers an hour in second gear. It's really quite hard work. So cognitive overload, that's another set of factors. Third and finally, Professor Lynn's team, they identify the cerebral atrophy as another whole set of factors. So cerebral atrophy is a medical terminology for brain shrinkage. We can see up to a 40% reduction in parts of the brain associated with speech, hearing, language, and memory when we've got a hearing loss that we've done nothing about. Because the most common forms of hearing loss, they're presenting a barrier or a hurdle for appropriate stimulation to get through to the hearing centers in the brain. And it's these parts of the brain are much like other parts of the human body. If we don't use them, we really do start to lose them. we can actually see some disorganization effects occurring as well, and I've got some visuals on that a little bit later. But you might be thinking, well, gee, thanks, Andrew. I've, come all the way here. A few people have travelled over an hour and a half to come to this lecture. Lovely day outside, and you might think, well, I've come all this way for Andrew just to talk to us all about doom and gloom. Well, the good news is that when we can catch hearing loss in time and provide the correct treatment to it, we can actually see a reversal of a number of these downstream trends. So I'm going to be talking a bit about the correct treatment of hearing loss, and really for the most common forms of hearing loss at this point in time, the most appropriate and effective treatment is in fact hearing aids, or we like to call them hearing devices. Now, this session is not about ramming hearing aids down your throat or anything like that. It's to hopefully help you just consider hearing loss in a bit of a different light, and just how we think about it, particularly in the order of priority when we're thinking about which health conditions are we most likely to attend to. Because the fact is, here in Australia, we're 5 times more likely to do something about a vision loss than we are a hearing loss. And yet, as we'll dive into later, when it comes to the links between vision loss and cognitive decline, it barely gets a mention in the literature. Nothing, and when it does get mentioned in the literature, it's of pales in comparison relative to what we're seeing in relation to hearing loss. So just quickly about cerebral atrophy. We can, when we, those shrinkage effects that we can see in the brain, it's hard to find really clear imagery of what's going on. Just to give you a bit of a sense as to how people with normal hearing compared to those that have hearing loss, how does that compare in terms of volume? Well, where we see the biggest effects with hearing loss on brain volume is in an area that we call the right cluster, which is part of the brain that's just kind of adjacent to our ears. These bars here are showing the difference between people with normal hearing in blue and those that have a hearing loss. Specifically in the right cluster, you can see that the higher the bar, the more volume we have. So we're going up here. This is someone who's got this is a group of people that have normal hearing. Their brain volume in the right cluster relative to those that have hearing loss here in red. We can even see if we look at whole brain grey matter, we can see up to a 10% reduction overall. We see here we've got the people with normal hearing blue, those with the hearing loss there in red. This is an individual gentleman. This is a 68-year-old man who has normal hearing in one ear and a severe hearing loss other ear. And you can see just above that red arrow here, we've got a reduction in brain volume relative to the other side. So fortunately, what the research is also telling us is that when we can apply the correct treatment to this hearing loss, we can see a reversal of that trend. This particular study looked at the average in 14 people's brains that hadn't worn hearing aids before. So they had a moderate hearing loss, about a 25 to 40% hearing loss, hadn't worn hearing aids before. They came into the lab, had their brain scanned, and what the researchers found is that there was underactivity in the hearing centers in the brain and an overactivity in these frontal parts of the brain here. So these frontal parts of the brain in people with hearing loss are working much harder. And if we look at the brains of people that have a long-standing hearing loss, they can actually get a thickening in this frontal part of the brain, because those frontal parts of the brain are really hard at work and putting together different bits of information from different parts of the brain. So for the most common forms of hearing loss, people are hearing parts of words, and most commonly are missing out on all of the consonants, which carry most of the meaning. So they're needing to get that information from somewhere else, most commonly from their vision. Often that's not enough. They need to add in some context to add in the gist of what's being talked about. Hopefully they've got enough information to follow the conversation. So these frontal parts of the brain, they are really hard at work. Putting together bits of information from different parts of the brain. So these people, they receive what I like to term the holy trinity of the correct treatment for their hearing loss, which is good quality and appropriate for their hearing devices, fitted using best practices, which we know should always be used, that we know aren't always used. And third and finally, they kept their devices in for at least 12 hours a day. Now, we know that most people that own hearing devices here in Australia, we know that most people don't wear them. We know how often people wear their hearing devices because they've got these teeny tiny little databases in them. And we like to check. A major study was done, 15,000 hearing device owners here in Australia. And what they found was that a third of the people that owned these hearing devices really weren't wearing them at all. They had them in the bathroom cabinet. They had them in the top drawer. Some of these people that own hearing aids were found to actually wear them in their pocket, really anywhere but their ears. Another third of people in the study, what I'd like to call my reading glass wearers. So they're the devices on to come to, say, a seminar like this, or head out with family and friends, but most of the time they're not wearing them. Only a third of people that own hearing devices here in Australia actually wear them as they should, which is at least 12 hours a day. If you've got hearing devices, if someday you need them or you know someone that has them or needs them, the best advice that any audiologist can possibly give you is that those devices really need to be in for at least 12 hours a day to get the full value and benefit from them. The best evidence that there are brain health benefits from treating hearing loss comes from these important studies where people people utilize the treatment on a consistent basis. And I've got to say that in my personal experience in treating hearing loss, the differences that we get in outcomes in people that wear their devices like their reading glasses, so kind of like once in a while, and those that are in the habit of keeping them in at least 12 hours a day, again, it really is like chalk and cheese. So they receive the holy trinity of the correct treatment for their hearing loss in this study. I feel a little bit awkward when I talk about it, particularly following a presentation that I did. I'm not sure if you know U3A, or it's a group called the University of the Third Age. They invited me to come and talk to their members about hearing and brain health. They didn't have a professional kind of setting like this. It's a nice setting, but they actually had me presenting to their group in our church. And so I was up on the altar preaching to the congregation about the holy trinity of the correct treatment of their hearing loss. I feel a little bit less awkward talking about that kind of thing here. So they came back after a year of keeping their devices in at least 12 hours a day. And what the researchers found was significant regrowth in the hearing centers in the brain. So the hearing centers in the brain in these people grew back in a way that we can call statistically significant, which is to say they didn't just grow back by chance. Probably my favorite study in this field of hearing and brain health was done at the parts of it were replicated here in the University of Melbourne, but the main study was done at the University of St. Louis. And what the researchers found was evidence of what we call cross-modal reorganization occurring in the brain. What does that mean? Well, basically what the researchers found was evidence of the visual centers in the brain starting to encroach upon the hearing centers in the brain. And they were able to demonstrate this by flashing visual stimulation into the eyes of the people in this study. And that visual stimulation was showing up in the hearing centers in the brain which it really shouldn't be there. And that's good evidence that as a result of having hearing loss, that the hearing centers in the brain, these people were starting to become disorganized. So an important point here is that the people in this study, they had a mild hearing loss. So they only had about a 25% hearing loss, the kind of hearing loss that we never used to care about. So even at mild levels of hearing loss, we're starting to see disorganization effects occurring in the brain. So again, these people, they received the holy trinity of the correct treatment for their hearing loss, so good quality, appropriate for them hearing devices, fitted using best practices, which should always be used. They weren't as strict in this study. They kept them in for at least 10 hours a day. And then they came back into the lab after 6 months. So in the beginning, I should mention that they did a range of tests on these people. They were seeing this, the visual centers of the brain encroaching on the hearing centers in the brain. And they thought, well, maybe that's going to make these people a lot better at lip reading. But what they found was that these people were no better at lip reading, 26 of them, no better at lip reading than their peers that had normal hearing. They did find, though, that the people with hearing loss were significantly worse. They performed significantly worse for tests for hearing and background noise in groups. And they performed significantly worse on a range of cognitive tests relative to people that had normal hearing. So they came back into the lab 6 months later, after wearing the hearing devices for at least 10 hours a day, had their brains scanned again. And what the researchers found was that visual stimulation actually showed up more directly into the visual centers in the brain. It got out of the hearing centers, which is good evidence that these parts of the brain were starting to become better organized as a result of having their hearing loss treated and treated correctly. They performed significantly better for tests for hearing and background noise in groups, and they performed significantly better on a range of cognitive tests. So short-term memory processing speed, reaction time, general executive functions, these things improve as a direct result of having their hearing loss treated. I had the pleasure of, me and my team actually had the pleasure of going over to Texas literally this time last year to do some intensive training in this area. Dr. Hannah Glick was one of the presenters, and she was talking through her findings in this field. And her team thought, well, we're finding these quite dramatic results in the lab. What happens if we go out to the community, find 100 people that just so happen to own hearing devices? What happens if we bring them in and scan their brains, do all the tests, and see what we find? What they found was that 40% of the people of these 100 people, 40% of them had their brains scanned, and they look very much like this, these quite elegant and dramatic results of having their hearing loss treated, the hearing centers in good shape, and so on. But for 60% of the people just out there in the community wearing hearing aids, what they found was their brains looked like they hadn't worn a hearing aid for a day in their whole life. On further investigation, they found that most of these people were underfit. So basically what that means is that their devices were not correctly fit to a hearing loss prescription. And most commonly, they were just on the factory settings or the factory estimates of what that person should be getting, but not fitted using best practices, which are a more objective process of helping us fit the hearing loss prescription. They also found that a lot of these people they weren't wearing their hearing devices near enough to get these positive brain changes. So I've become a bit of ask any of my patients, I'm a bit of a broken record about wearing hearing devices for at least 12 hours a day. I've just found really even just purely from a practical point of view, that my patients just get much, much better results when they keep their devices in consistently. And I've had the pleasure of working in 5 different international markets, most recently in the United States, prior to starting my clinics here 6 years ago. But in the United States, I've seen a number of studies that have looked at of people that own hearing devices in the USA, how often do they wear them? And I figure 10.8 hours per day is consistently comes up in the literature. Here in Australia, the average daily use of people that own hearing devices is 6.7 hours per day, which is I would say dramatically less, and that's a pattern that's been around for at least a decade. The thing is, the hearing profession here in Australia is actually quite unique relative to what we see elsewhere in the world. Australia has the most corporatized expression of audiology that we really see anywhere in the world. For instance, in the United States, most of the, like 2/3 of the profession is what we call independent. So of the clinics there, 2/3, around 66% are run and owned by a person like me, independent practice. And when you're in independent practice, it means that you're able to pick and choose the hearing devices that you work with. And I found also that independent practices are more likely to engage in the best practices that are required to really get the really great results. So here in Australia, most of the clinics are out there, chains of clinics, most of which are owned by overseas-based hearing aid manufacturers. And my primary concern about these clinics, and I'm sure they're all really lovely people that work there and have all their hearts right in the right places. But my primary concern is that when you go to one of these clinics, you can have any hearing aid that you like, as long as it's the specific type that they make. The problem with that approach is that there's not one manufacturer that has the right solution for the right person for the right hearing loss every single time. And what we're seeing is a rapid increase in the rate of technological improvement in hearing devices. So what might be the right solution for the right person today, there's a good chance that another manufacturer is going to have an even better solution 3 months later, 6 months later. And unless you're an independent clinic, you don't have access to all of the possible solutions that are out there. So United States, 66% of the practices are independent. In Australia, only 7% of the practices are independent. So it's just a bit of advice for you if you're looking to improve upon your hearing situation. I'm not saying you've got to come to my clinic or anything like that. I'll just encourage you to seek out an independent audiologist. You're just far more likely to get a much better result. So I'm going to give you just a really quick tutorial about how the hearing system works. I'm going to keep this brief. So Tiffany, who introduced me today, she helps me out at work, but she's also my fiance. Last time I gave this presentation, she wrapped me over the knuckles a bit. When it came to anatomy and physiology, she said I rambled on a bit. So I'm gonna keep this short and sweet, because we're getting married in 2.5 months' time, and I've had good counsel that I should learn to start doing what I'm told. So we'll keep this bit short and sweet. So how we hear is sound comes through our ear canals, hits our eardrum, causes it to move backward and forward. Depending on the pitch of the sound is going to determine how quickly that happens. Behind our eardrum are the 3 smallest bones in the human body. They help to amplify the signal and direct it into the cochlea, which is our organ of hearing. So those 3 smallest bones in the human body, each about the size of a half a grain of rice. Our organ of hearing, the cochlea, that looks like that style-type shell. It's actually about the size of a pea, and we have around 15,000 little nerve endings that sit inside it. The cochlea is beautifully arranged, kind of like the keys on a piano, from high pitch right through to low pitch. So depending on the pitch of the sound, we're going to determine which part of the cochlea becomes stimulated. So the high pitches, so very much like the strings on a musical instrument. If you're familiar with the strings on a guitar, violin, piano, you might be aware that the high-pitched treble strings are thinner, finer, more brittle, easier to break relative to the more robust bass strings. So we see the same pattern occurring in the human hearing system, which is why it's most common. It's really, really common to see high-pitched hearing loss. So well over 90% of the time, we see some variation on the same theme in the clinic, where our patients, their hearing's in better shape in the low pitches relative to the high pitches. As we go further in, probably our most important hearing structure in the brain is called the auditory cortex, and it too is split up from high pitch right through to low pitch. And so if we've got weakness in this yellow area here, we're going to have a corresponding understimulation in that corresponding yellow area there. And with today's MRI technology, we can actually see physical shrinkage of these unstimulated structures. If we don't use it, we really do start to lose it. So the little nerve endings, we've got 15,000. If we look at them under a really powerful microscope, they look very much like this. Nice and healthy when they're standing up nice and straight like that. When they get damaged, this is what a moderate hearing loss would look like under a really powerful microscope. So about a 25 to 40% hearing loss. These nerve endings, they still work when they're in this state, but we really do need sounds to be louder to help to stimulate the underlying nerve structures. We're actually born with as many of these little nerve endings as we're ever going to have. They don't heal if there's anything that happens to them throughout our lives. They don't heal, they don't regenerate. There's no medication, surgery, supplements that will bring them back. Once that damage is done, it's done. So we consider the most common forms of hearing loss to be permanent. So why I like to focus on the brain in my clinic, in my presentations, in the books that I've written, is because we could say that our brains are plastic, or that we have neuroplasticity in our brains. When I say that our brains are plastic, does anyone have any clue as to what I'm talking about? I'm hearing whispers there, so I'm hearing you can change it, it's adaptable, it's malleable. Yeah, that's all true. So in a nutshell, neuroplasticity, it's the capacity for our brains to change. And there's really three ways in which our brains can change. Well, three main ways. Firstly, for our capacity to form new connections in our brains. So whenever we learn something new, we're creating new connections in our brain. So if you learn something new this evening, you're going home with just a little bit of a changed brain. The second way in which our brains are plastic is via our capacity to strengthen increase the strength and speed of existing connections in our brain. So if we've got, just say if you learned something new this evening and you went home, came across a similar concept in my book, even better, taught someone else that new thing that you learned, you're strengthening those connections that you have in your brain. So that will happen if you practice a skill really well, or you learn something really well. Those existing connections in your brain, they'll strengthen. The third way in which our brains are plastic is via a process that we call pruning, kind of like pruning a tree. It's when we've got parts of the brain that are understimulated. Our brains are very efficient at repartitioning resources off to different parts of the brain, away from areas that they're being underutilized or understimulated into areas where they will actually get utilized. Kind of depends on which part of the brain that we're talking about in terms of how quickly this will happen. When it comes to learning new things, learning new facts, if we're not revising those, we can forget those actually pretty quickly in as little as half a day. With the links between our ears in our brains, and we've got about 10 million of them, it takes around 10 years of understimulation for us to start to see a permanent pruning away of these links between our ears and our brains. So this trend that we have of putting off doing something about a hearing loss for 10 years or more, in my experience, what we're really putting off is the possibility that we're really going to get a really great outcome in the clinic. There's really quite basic ways of, so what tends to happen when I'm seeing someone in the clinic that has a long-standing hearing loss, so it's been around for 10 years or more, 10 to 12 years, and it hasn't been treated, we can start to see some distortion coming into the system. There's a very basic test that we do routinely where we have our patients repeat back different lists of words. And what I find when I see someone whose hearing loss has been around for say 10 years or less, almost always they're getting 100% on those tests. However, when that hearing loss has been around in a significant way for 10 years or more, it becomes progressively more difficult to get 100% on those tests because we're starting to see some distortion coming into the system. And it makes it then really difficult for us to bring back that clarity, because there's what's likely to have occurred is a permanent pruning away of some of those underlying connections between the ears and brain. One of the reasons why I harp on, like broken record to my patients about keeping their devices in at least 12 hours a day, is that just say if I've seen patients that have come in with a 25 to 30% hearing loss, long-standing patients have come in over about a 25-year period into a clinic, records of what's happened over that time. For those that have been in the habit of keeping their devices in for at least 12 hours a day, they've started at 30% hearing loss, 25 years later, they might be 75 or 80% hearing loss. They're maintaining, a lot of them are still getting 100% on their speech scores because they've been able to keep those hearing centers in the brain intact and working really well. It is dependent on those devices being fitted correctly and worn consistently, but there's every reason to suggest if we keep our devices in on a consistent basis, we retain that most important capacity that we're trying to achieve as audiologists, and that is clarity in speech understanding. So can anyone tell me what the number one cause of hearing loss is?
Noise.
Noise. That's number two. So overexposure to noise, that's the second leading cause. Infection. It's pretty common. Rarely does it lead to a permanent hearing loss. So usually it's temporary and it resolves. But that'll be about number 5. Yeah, in terms of permanent. Aging. Yeah, excellent. Well done. So aging is the number one cause of hearing loss. Why is aging the number one cause of hearing loss? It's because it will happen to essentially everyone that lives long enough. Noise-induced hearing loss is the second leading cause of hearing loss. It gives us a similar pattern on the in terms of test results. People are missing out on those high pitches relative to the low pitches, and both age-related and noise-induced hearing loss are going to result in difficulty hearing in background noise and group situations. And they're going to impact on our ability to hear those consonant sounds primarily. You look like quite a proactive group. I'm guessing most of you have had your hearing tested at least at some point in time. Most of you? I'm so sorry. Okay. Many SSEs. Oh yeah. So Meniere's disease would come in terms of causes of hearing loss. It comes into the hereditary category, which would be, I guess, the third leading cause. Yeah. So, but for the most common forms of hearing loss, if you've had your hearing tested before, this might be familiar what we've got up on the graph here. So up on the screen. So basically, how it works, the audiogram is like the most common test that we do. When hearing is absolutely completely normal, it's going to be right along the top here like this, which is low pitch and sits there, high pitch and sits with volume getting louder down this way. So the further down we need to go, the louder the sounds need to be for you to hear them. And what I've done is I've just superimposed a really common age-related hearing loss that we see all day, every day in the clinic, where we measure the right ear with the circles, left ear with the crosses. We're starting off with the hearing in relatively good shape in the low pitches, and we're sloping down in the high pitches here. So from a practical point of view, that's going to mean that a person with that kind of hearing loss, they're going to be able to hear the vowels, like the A, E, I, O, U vowels, quite okay, but not always the consonant sounds, which are like the beginnings and ends of words. And that can lead to, when we're talking about the aspects, what in terms of the links between our hearing health and our brain health, one of the subset of factors there is brain overload. So this filling in the gaps exercise that we need to do to compensate for a hearing loss really does put a consistent load onto our cognitive abilities. So I'm going to give you a bit of an exercise just to demonstrate that now. Up on the screen, we can imagine this is like a text message. So what you're getting there is the benefit of the consonant sounds without the vowels. And I'm guessing most of you will be able to follow what's being said there. Now try it with an age-related hearing loss. So what you're getting there is the benefit of the vowels. So the vowels, they give us the perceived volume of speech, the perception of loudness of speech primarily will come from the vowels. However, the consonants will typically give us the clarity and the meaning of words. So some of my patients, they've come in initially a little bit confused because they don't know whether they've got a hearing loss or not, because they're hearing, their low pitch hearing in pretty good shape. They know someone's talking, they're getting the volume, they can hear someone knocking on the door, coming up the driveway, those low pitch sounds, things like that. But when it comes to a following conversation, particularly when there's competing noise, that's when it becomes exceptionally difficult. Also, certain TV programs, hearing people from another room, they know someone's talking, but just exactly what they're talking about, that becomes an increasing challenge. So that's the full sentence there, which you or text message, which you may have guessed just by consonants. Vowels don't carry a whole lot of meaning, so it can start to sound like mumbles. Often, I have people come into my clinic for the first time, just that have observed that all of a sudden people are starting to mumble, particularly younger kids these days. But it tends to, like when we start to lose those consonant sounds, typically a lot more people seem like they're mumblers than there actually are. Statistically, around 2% of the population actually mumbles, but that percentage tends to be perceived to increase as our hearing goes down, because when we're not getting those consonants, we're just getting those vowels. That's what it has to sound like. So I just mentioned Nicole passed around a feedback form to all of you there. It's just really helpful if you can help fill that out. That'd be great. At least we'll know that you've arrived, and it's really informative for us to get some feedback as to whether our presentations are too technical, whether we're going too long, or if it's if we're keeping things relevant to you. At point 2 there's a question about tinnitus. So tinnitus ringing in the ears. Is that something that's ringing in the ears, tinnitus? Is that something that a number of you are concerned about, bothered by? Yep. Okay. It's tinnitus is really common. It's a whole seminar topic on its own. As there's a few people in the room that are interested to hear more about it. When we get toward the end in questions, I'll spend a little bit of time talking about tinnitus. But what we've done, because it's we know it's often one of the first signs of hearing loss. We know that over 70% of people with hearing loss also have tinnitus. So most of my patients also have tinnitus as well as hearing loss. And part of the treatment is for anyone that has tinnitus, whether they've got hearing loss or not, is to learn the facts about it. We know that there's a lot of rubbish about tinnitus floating around on the internet, a lot of rubbish about tinnitus actually coming out of doctors' offices. So what we've done is put together the what we know to be the most, I guess, factual information about tinnitus and some really quite useful tools to help to manage the condition. We've put that all into kind of a big long resource file, a few videos and so on that we call our tinnitus resources. If that's of interest to you, just tick yes, please send me free tinnitus resources and we'll email you out our tinnitus resources file. Just make sure that you've got your email address on top there and we'll send that one out to you. If it wasn't obvious, I actually quite enjoy giving these presentations. So if you're part of a group, be it a Probus club, a U3A, or even an independent retirement community that accept guest speakers, I like to have guest speakers like myself along, the kind of group that may be interested in this topic. If you can write down just the name of that of your group and your contact, and either Tiffany or Nicole will come back and see if we can see if that's appropriate for your group and whether we can work out a time. It's something we do most weeks, is those kind of presentations, and we really enjoy them. And finally, one thing that I offer to anyone that's really taken the time to come to one of my presentations is a complimentary telehealth consultation with me. So we do that either over video or over a phone call, and that helps me understand your condition a bit better, and whether there may be benefit in seeing me personally, or whether I can recommend someone to you. Typically, we leave about 15-20 minutes aside for that. No cost at all. If that's of interest to you, just please tick yes, contact me to make a booking, and we'll arrange a time to book you in, and we'll get that done. So dementia prevention has become it's become quite a hot topic. Currently, dementia is the leading cause of death for women in Australia, the second leading cause of death for men. Over the past 10 years, dementia-related death has actually increased by 68% in Australia, whereas the leading cause of death for men, coronary heart disease, has actually decreased by 19%. So the medical community have become better at treating different parts of the body. However, when it comes to brain health, despite the billions of dollars that have been spent on pharmaceutical interventions to help treat diseases of the brain, they really haven't got very far. So really at this point in time, with regard to dementia, we don't have treatment. All we really have is prevention. So I'm tethering, it's okay, I just need to get that out of my mouth. So the Lancet Journal, who is the leading medical journal on the planet, they've done 2 major reviews looking at what the world's best research tells us about dementia prevention. And basically they've come to the conclusion that that based on the world's best research on dementia prevention, up to 40% of cases of dementia could be prevented through long-term lifestyle modification. And they've essentially come up with the top 12 list of the top 12 things that we can do to help reduce our risk of developing these diseases of the brain. And they've rank ordered them into, order of significance. And number 2 on the list, if we're thinking about what are the best things that we can do to help reduce our risk of disease of the brain, developing a habit of lifelong learning is, I guess, the Lancet Journal defined that as really the second most impactful thing that we can do to help reduce our risk of developing these diseases of the brain. So I applaud you for taking time out of your busy schedules to come and join a session like this. And hopefully you're learning a thing or two. And I just encourage you to do what you can to develop a habit of lifelong learning. So this is the Lancet Journal's top 12 criteria up on the screen here. So less education is second on the list there. Right up on the top of the list is, in fact, hearing loss. So the Lancet Journal defined hearing loss as being the number 1 modifiable risk factor for the prevention of dementia. Modifiable meaning there's something that we can do about it. Why is hearing loss at the top of the list? Well, we know hearing loss is really common. It will happen to essentially everyone that lives long enough. We also know that the impact on our brain health can be devastating. And also, hearing loss is highly treatable, and particularly when it's the right treatment, and it's fitted correctly, and that the treatment's actually worn ideally on a full-time basis, we can see a reversal, a number of the downstream trends that we see with hearing loss. Interestingly, as we go down the list of these significant factors, so we've got hearing loss, less education, smoking is there. I'm not sure how many smokers we have here, but depression, social isolation are next on the list. And these 2 aspects we've known for decades are significantly correlated with hearing loss. So people that are with hearing loss are significantly more likely to become depressed and significantly more likely to become socially isolated. So if we look at the factors that either directly relate or indirectly relate to our ability to hear well, according to the world's best research on the subject, more than half of the things that we can do to reduce our risk of developing these diseases of the brain relate to our ability to hear well. And if we're serious about establishing a habit of lifelong learning, then it's going to be helpful to be able to hear well if we're going to attend lectures, workshops, interact with other people in a learning environment. So I mentioned Professor Frank Lynn's work. His team were behind that really important initial research that looked at increasing levels of dementia risk as a result of increasing levels of hearing loss. And what happened since those studies were released is that questions were starting to be asked about, well, okay, we can see that hearing loss has devastating impacts on brain health. What happens when we apply the correct treatment to that hearing loss? And his team, they sourced $40 million worth of funding to conduct the largest experiment that we've seen in our field. And it was basically looking at, really intensively looking at what happens when we have 1,000 people in the study, we fit half of them with hearing aids, half of them without hearing aids. Let's see what happens over a 3-year period. Well, basically what they found was that in adults that were at risk of cognitive decline, the progression of their cognitive decline was half relative to people that didn't wear hearing aids over that same 10-year period. So to summarize, in older adults, increased risk for cognitive decline, hearing intervention slowed down loss. So hearing intervention, hearing devices, slowed down loss of thinking and memory abilities by 48% over a 3-year period. I should add that as a group, the memory abilities of those people that wore hearing aids didn't decline in a measurable way. We can't say the same for those that didn't wear hearing aids. So 48% reduction or slowing down in cognitive decline. We don't see anything like those kind of figures when looking at the various medications available, let alone other interventions that we might think of for slowing the progression of cognitive decline. It's a rather massive effect. Also, over a 3-year period, there was a study done at the University of Melbourne, and basically what they were looking at in this research was impact of treating hearing loss on cognitive function. So there were 160 people in this study, and basically they half of them got hearing aids, half of them didn't, and they were measuring their cognitive ability over 3 years. But they took 2 separate readings, one at 18 months, one at 3 years at the end. But this was done in Melbourne, and what happened is for the first 18 months, this was just kind of like pre-COVID. They found that people that in the study were wearing the hearing devices consistently, and they improved on 5 different dimensions of cognitive health. Then COVID happened and all the notorious Melbourne lockdowns occurred. And they found that the people in the study, they started wearing their hearing devices less. And they were able to measure that because they all got these little databases on them. And not only that, these people were stuck at home in lockdown, not interacting with different groups of people. And they found that these people in the study that wore hearing aids, they maintained improvement in 3 dimensions of cognitive health, but they actually dropped off on a 5th dimension, which is general executive function, the integration of a lot of these cognitive abilities. So what that tells me is that, well, first of all, these are rather dramatic effects. Improvement of cognitive function in people wearing hearing aids relative to those that don't. But unless we maintain that habit of keeping those devices in, and there's also something to be said for ongoing social interaction, there's a good chance we may not maintain those improved cognitive abilities or to get the potential of what those devices can really bring us. So I'm going to talk just a little bit about social isolation now. And I think there's just a couple of studies that relate to this that I think are pretty relevant. One of them was done at Harvard University. It's an ongoing study. It's been going for about 85 years. It's called the Harvard Happiness Study. They're not just looking at happiness. Well, it started out as a happiness study. It's kind of morphed into a study of well-being. And basically the research question was really, it started out as, well, what is it that makes a happy life? And they followed about 1,700 people over their whole entire lifespan. And more recently, the study has extended into family members and so on. Huge study. And basically they're trying to answer the question, what is it that makes a happy life? And that's kind of morphed into what is it? What kind of lifestyle gives the highest levels of well-being? Is it how much money you make? Is it where you live or where you grew up? And what is it that the people that have the highest levels of well-being, what is it about them? And basically what they've come to the conclusion is that the people with the lowest levels of well-being, or you might say the least happy people, tend to be are the chronically socially isolated and the chronically lonely. They're found to have a lower life expectancy, significantly more likely to become depressed, and when measured, their brains are physically smaller than, say, those that are more socially connected. Those found to have the highest levels of well-being in the study were those that had the highest quality relationships. So particularly those close relationships, so the people closest to them, those relationships were of high quality, and that has overwhelmingly been the highest predictor of well-being is the quality of those close relationships. So perhaps you can help me out here. What kind of what needs to be present in a relationship for it to be of high quality? Can anyone help me out here? Conversation. Right? Communication. Excellent. Excellent. I think we can all agree that at least on some level, communication is rather fundamental for any relationship to really be of high quality. And if we think about hearing loss, it's the most it's the most common form of communication difficulty that they can have. What we tend to find, and when we're thinking about social isolation, sometimes we talk about that and people assume, oh, well, you're just talking about parties and pubs, that doesn't really interest me, and so on. That social isolation can actually start to occur on the domestic front. As the hearing goes down, what tends to occur is communication starts to become really left to the basics. Those throwaway lines, the rich nuance, subtleties in communication start to become progressively more difficult, potentially more awkward. There becomes a point where we start to stick to the basics, which is not just isolating for the person with hearing loss, but isolating potentially for anyone that's really interested in having a rich, nuanced dialogue with that person. Another study that I'll briefly mention was done in the blue zones. So the blue zones, they're parts of the world where people are significantly more likely to live to be over 90 or 100 years of age. There's several blue zones. There's one in Costa Rica, one in the United States, Japan. And they've all got, there's commonalities amongst them, and researchers have been scrambling to find out, well, what are the trends between the blue zones, what is it these people are doing that we can learn from and apply to, hopefully live a long and happy life. So there's various similarities between them with lifestyle and activity levels and diet and so on. But there's one particular blue zone where they found a peculiar trend. In all of the blue zones, they found that life expectancy between men and women was like women would outlive men by close to 8 years, which is exactly what we see here in Australia, also in the United States, most of the Western world, that same trend. So all of the blue zones except one. So one of the blue zones, the researchers couldn't find that there was any difference in the life expectancy between men and women. And it was in the blue zone in the island of Sardinia. And believe me, these blue zones, they're under a microscope because there's a keen interest. We know we've got an aging population. What is it these people are doing that to live such long and happy lives? And particularly the life expectancy between men and women, that hasn't really been all that well understood. So what is it these guys are doing to be equally likely to live to be over 90, over 100 years of age? And what the researchers found when really intensively studying these communities was that they couldn't see any difference between the priorities that men and women gave to relationships. They found that men were equally more likely to put in effort for family gatherings, they put in high importance, gathering, catch-ups with their mates. They to a very similar degree to the women in these communities. Whereas if we look at the other blue zones and And I guess as a general statement, differences in proclivities in Western men versus Western women. I've got to watch what I say a little bit these days at universities. There's some universities that will have you believe that there's no such thing as difference between men and women. So I've got to watch what I say. But when we look at objective data and we look at proclivities and differences in preferences, well, what the data indicate is that women, there's exceptions but on average, have a proclivity or a preference toward people, whereas men, and there are exceptions, men tend to have a higher proclivity toward things. What they found in this blue zone of Sardinia, where they couldn't spot any difference in life expectancy, was that the men in these communities as a whole had a relatively equal proclivity toward people. And it had what appeared to be a direct bearing on their longevity, right? So I'm just going to ask you a really quick question, and this is not a trick question. I'd like you to consider you're given a choice, and there's no real right or wrong here. I know I'm an audiologist and it's a hearing lecture and but I'd just like to ask you, you've got a choice, and the choice is to become completely blind or completely deaf. So basically, you either get to keep your hearing or you keep your vision, but you can't have both. When faced with that decision, who here would choose to keep their vision? Great. Okay. All right. Thank you. That bit over half of you. So who here would choose to keep their hearing? Great. Okay, excellent. Now, if you don't mind, I'm going to put a couple of you on the spot. So those of you that chose hearing, only in the blue dress. Yeah, do you mind if I put you on the spot? Was there something specific about your hearing that made you want to hold on to that? Music? Excellent. Great. Do you mind if I put you on the spot? Was there something about it?
Yes. Hearing what sound?
Hearing your fingers? Excellent. Yeah.
Friendship, the laughter that increases.
Yeah. Okay, excellent. So interaction with other people. And who else chose hearing there? Yeah. Okay. Do you mind if I put you on the spot? What is it about your hearing that you want to hold on to?
Music, just
Voices. Yeah, excellent. Great. So communication and music. Well, I think we're dealing with a pretty enlightened group here. So when we ask that same question to informal research settings, what they find is that 83% of people will choose to keep their vision, 17% of people will choose to keep their hearing. As it happens, around 83% of people with a vision loss will go and do something about it. A generous estimate of people that have a hearing loss do something about it and actually utilize the treatment for at least 12 hours a day. A generous estimate is 17% of people that could actually benefit from that. I reckon it's lower based on what I've seen, but similar kind of a split. I think we had about a quarter of people here choose hearing, and for those of you that are put on the spot, the thing is usually what happens when in research settings and when I do these talks, we put people on the spot and we ask them, well, what is it about your hearing that you want to hold on to? Rarely does communication ever come up, right? So people I like the music, which is great. There's nothing wrong with that. Some people could not live without the sounds of nature. Some people say, "Oh, I like to hear babies cry." Now, how hearing babies crying can be like your favorite sound. Oh God, absolutely no idea. But people pick it. but rarely does communication ever come up. So I just tend to think that I don't know, I guess in my experience in treating hearing loss for as long as I have done, I tend to think we've got a bit of a cultural blind spot for communication in that I think it tends to be something that we have I think we've got a tendency to take it for granted until it gets to the point where it's near on impossible. That's when we kind of start to value it. Interestingly, I did a lecture in Melbourne about a year ago, and 100 people along, and the only two people in the audience that chose hearing in the audience was a husband and wife. And I did what I used to do, and I put them on the spot and said, "What is it about your hearing? Why did you put your head up?" And they said, "Oh, it's because we're both ophthalmologists, so we're eye surgeons, and we've been doing it for 40 years." And the thing is, in our work, people go blind. You know, it's kind of an occupational hazard. But also people have comorbidities in that the thing that made them blind often made them deaf, and sometimes they get their eyesight back and so on. So they have, I guess, first-hand experiences of seeing people that have become blind, people that have become deaf, and in their estimation, deafness is far more devastating because of that, the impact it has on communication and therefore on relationships. So one person who was, I guess, deaf, well, she was deaf and blind. Helen Keller was the first person to receive a university degree, first deaf and blind person. And she was asked all the time, what's worse, deafness or blindness? And hands down, any day of the week, she would choose to be blind over deaf. And when asked why, she would say, well, that blindness separates us from things, but deafness separates us from people. So I think I've mentioned a few times I'm like a broken record about keeping devices in. One thing that it's just a real focus of our clinic. We've put together a guide, and occasionally we do workshops that we call out of the box workshops. In that the key message here is that if we're going to be successful, then the devices need to be out of the box and actually being worn. And we've developed, I guess, a set of tools to help people really get off on the right foot. And we've got a bunch of that actually on our. We've got a channel now on YouTube called the Hearing and Brain Health channel, and a bunch of our out of the box materials on that. We've been working with a charity in Cambodia for some time. Since 2012, I've been over there helping to train their audiologists on how to fit hearing aids. When I first went there, there were 14 audiologists, and now they've got 11. Another way in which we support them is we know for a fact that there's tens of thousands of hearing aids in Australia that are in top drawers, in bathroom cabinets, lying around not being used. So if you've got some of those lying around your home, might be, if you've got hearing aids, you might replace them. But if if there's pre-loved hearing devices, if you can send them into not to that clinic, if you could send it into our clinic in Macquarie Street, that would be great, and we'll fix them up and send them over to Cambodia, where they will actually get utilised. So I won't give you my address. It's on my business card, which is in your little pack that you've got there. But I would just encourage you to think about hearing loss just like you would any other major illness. So coronary heart disease, diabetes, cancer. There's no blanket cure for these chronic illnesses, but there are effective treatments, and those treatments are most effective when they're delivered early. We know that hearing loss is a progressive degenerative disorder with neurologic involvement, and we get our best results when we catch it early and we treat it early. So thank you so much for your time and attention this evening. Now, I've got time just for a couple of questions if there are any. Tiffany, anyone on Zoom have questions that come up? Actually, what I might do, if you don't mind, can you all wave to our people on Zoom? See, they can kind of see you there. Okay. So I had a question about tinnitus earlier on, ringing in the ears. There's a number of people here that I think curious about that. I might just mention just a couple of things about tinnitus, but it's a whole seminar topic on its own. And it doesn't necessarily affect absolutely everyone here. So I'll keep it pretty brief, but it's one of the first signs for a lot of people. It's one of the first signs of hearing loss, often together with difficulty hearing in background noise and groups. What we see in people with hearing loss is that as the hearing goes down, if they've got tinnitus, the tinnitus can often be perceived as being louder. Put simply, the more hearing loss we have, the more quiet parts of the world are relative to people that have absolutely completely normal hearing. So when we treat that hearing loss, what we're doing is we're reintroducing a lot of the sounds that aren't being heard as the hearing loss, and that can help have a masking out or covering up effect of tinnitus. Another thing that happens when the hearing goes down is we get this thing called brain gain. So the hearing centers in the brain, they start to become on high alert for whatever sounds that they can pick up. So as the hearing goes down, the sensitivity of the system tends to turn up somewhat, and the volume at which we hear the tinnitus can get turned up as well. So when we treat that hearing loss, and critical with tinnitus that those devices are being worn on a really consistent basis. Over time, the hearing centers in the brain may start to relax somewhat because they're not having to work so hard. So the volume at which they hear the tinnitus can get turned down. The leading medical journals in the world, I've seen a couple of meta-analysis, which is basically we're looking at what is the world's best research in this area tell us about what we can do about tinnitus. In the presence of hearing loss, hearing aids, hearing devices are hands down the best treatment for tinnitus. And we always coin, whether it's hearing aids or people that aren't hearing aid candidates, always learning the facts about tinnitus, because the better we can understand the facts about the condition, we're taking away the fear of the unknown, helping to get hopefully even a rational thought about it. And what we tend to find is that the less we worry about it, the less we focus on it, the less it becomes this. Like a realistic goal that we want to get to with tinnitus is to get it off into the background, what we call habituation. So habituation is like refrigerator running, coffee, sounds around the home, things like that that are not important to listen to all the time. If we don't notice them most of the time, but we can hear them when we're out for them, it's likely we're habituated to those sounds. And that's an entirely realistic goal with tinnitus. Research indicates that when people are given the right advice and the right tools, there's a 97% success rate. It's not overnight. Often it takes a bit of time and a bit of persistence. But we're trying to get it away from being front and center of attention, off into the background. If we listen out for it, we might hear it, but we're not hearing it all the time. And still think, oh, okay, because you're not getting rid of it completely. What you're saying is that there's nothing you can do about tinnitus. Well, that's just like saying, just because you can't cure cancer completely, there's nothing at all that you can do about cancer. There are effective treatments for cancer, and equally, there are very effective treatments for tinnitus. Are we saying we can cure it? No. Does it go away for a lot of people? Yes. But sometimes it takes just learning some tools, applying some of those tools, but having confidence that it's a highly treatable condition.